Yes, we can.
All right, perfect. So thank you again for the kind introductions, and I'm glad there's a lot of people here that are back for this second part of the program. And so this part here is going to focus a lot more on the clinical applications of platelet-rich fibrin. We'll cover what we do in dentistry. We'll also give a little sneak peek at all the work we're doing in the facial aesthetic field, as well as textbooks related to that. Interestingly enough, when I first gave all my details, I'd written 5 textbooks, but this year we've already written 2 new ones, and I'll share with you guys one of them.
Okay.
It's quite interesting. It's another PRF book that was just recently written, and there's another one that's being written right now on PRF in the periodontics world. So I'll speak about those 2 books as well as we go through this. So just a little background about myself. A lot of people know me as the work that I do in development of biomaterials, etc. I work in private practice, typically 3 days per week, and we do a lot in the regeneration world. So with these other doctors, which I'll share with you guys all the work that we do together, we're really focusing more, and these doctors are all dedicated to, stop with pharmacological drugs and giving people drugs, whether it be for knees and this and that, or Alzheimer's, and just trying to get the body to regenerate itself. All of them we have in common that we all use PRF in our practices, and we'll speak to all the work that we're doing together. I wanted to review as well one extra point that was made kind of in the questions that were asked just in the last course. When we're looking at platelet-rich fibrin as a whole, for those that weren't there last week, I highly recommend you guys get the opportunity to rewatch that lecture, because it really talks about the basic science about how we separate these cells based on their density. And when you look at these cells, the red blood cells are always the big ones, and they go down first. The white blood cells are slightly smaller, but they're very similar in size. The platelets are very similar, very much smaller than the other 2 cell types. So when you're looking at separating cells based on density with the centrifuge, the platelets can quite easily get through the layers effectively. The white blood cells and the red blood cells are so similar in weight and size that it really takes a fine-tuned device to do this. And last week we talked about the fixed angle devices and the problem with these and the reasons why we don't use them. When I talk about facial aesthetics, when we do those courses, we tell doctors and orthopedic surgery and facial aesthetics, just straight up, nobody uses them. And we've had hundreds of clinics that we trained. And the reason why is because on a fixed angle device, all the cells, when that G-force is pushing, is all going towards the outer surface of this wall. So just as a little review, when that heavy red blood cell is pushed very fast and this thing's spinning, that heavy cell goes to the back of the wall, and then it's a heavy cell, it starts going downwards. So everything's always going to the back and then downwards. And when those light cells they start at the bottom here and they get spun very, very quickly, they go to the back, and then they have to somehow find the way up this hill to get to the top part. And they come in contact with these red blood cells, and they don't actually make it to the upper layers, okay? These devices here, the fixed angled centrifuges, should never be used to separate cells based on density. And there's a lot of confusion in the field, because there are people that will say different things. You can use this, you can use that. And I just wanted to share with you guys actually real scientific research articles related to this, that those devices, they should not be utilized to separate cells based on density. And when people take our courses and they really want to understand, what they're doing in the PRF world, these are things that we just, we get rid of, and people understand that. When you work in a real research lab and you want to separate anything, not just cells, but any kind of matter based on density, we always spin in a horizontal system. The tubes swing out, as I showed last course. You get a bigger difference between the RCF min and the RCF max, okay? And what happens is those heavy cells that start at the top, they'll go down, but the light cells, they can more easily get to the upper layers. Instead of having to climb up those hills as they do on a fixed angle device, they just free pass, okay? And they cross. So this is something that's very well known amongst, any type of researcher. But if you want to learn more related to fixed angle versus horizontal centrifuges, I put this slide up so that anybody can see. This is just if you go on Google and you do a very simple search and you type in horizontal versus fixed angle centrifugation, there will be a lot of companies that will have different explanations of where you use fixed angle and where you use horizontal. We were not the first people to invent horizontal centrifuges. They've been around in research labs for years, like 50, 60, 100 years. And these are big research or laboratory centrifuge companies such as Drecker, Thermoline, Eppendorf. These different centrifugation companies will literally write, and it's found everywhere online, what you use a fixed angle device for, what you use a horizontal device for. And so just to review this, when you look at these companies, and again, you can just go directly to these websites, advice swing out rotor or fixed angle. When you look at a swing out rotor, this rotor is particularly useful when samples are to be resolved in density gradient. The longer path lengths permits better separation of individual particle types from a mixture. This rotor is relatively inefficient for pelleting, okay? And people that use fixed angled centrifuges, these are designed to pellet to the bottom of a tube, okay? And a lot of people in science, we know what we do with fixed angle centrifuges because we pellet cells all the time, especially when we do stem cell research. What happens is when you have a fixed angle device, when those cells, if you want to send all the cells to the bottom of a tube, so example, let's say I have isolated stem cells, I grow them up, so I get them from a tissue, I put them in a tissue dish, so I'm growing them up on tissue culture plastic. When I trypsinize these cells and I have them in a liquid and I put them in a tube, when I want to concentrate these stem cells, what we do is we pellet these cells. And what that means is that all these stem cells are floating here in this liquid, and I want to get them all to the bottom, remove the liquid, and concentrate these cells. Much more effective to do that on a fixed angle device. And the reason why is on a fixed angle, if you do this horizontal, these cells that are here, they got to go all the way to the bottom. It takes a long time. When you use a fixed angle, the cells that are floating in this solution, they just go poof against the back wall, straight to the bottom. And then what we do is we remove this liquid, and then we have a concentration of cells there. So if you go on these websites that explain the difference between swing out rotors and fixed angle, when you look at the advantages of a fixed angle device, recall that the more dense materials will separate towards the angle of the G-force. Therefore, in swinging bucket rotors, the pelleted material will form at the bottom of the conical tube, while tubes processed in a fixed angle rotor will form on the side. This could be problematic if the solids get caught in the angle of the tube. So what happens is that when you use a fixed angle device, everything is going towards the back wall, and everything is getting caught in the back wall, and then it's getting sent down to the bottom of the tube. When you use platelet-rich fibrin, you're not taking samples from the bottom of the tube, you're taking them from the top. And that becomes very problematic. And it's one of the reasons why we don't recommend using those fixed angle devices. So when I showed these, because maybe this was difficult for some people to understand, when you look at the fixed angle rotors, everything goes towards the back wall. And that's what you see here. All the sample is collected on the back walls, okay? And unfortunately, those cells, they don't make it to the upper portion of the tubes because these little dots here are found all the way down. They don't make it to the top. Okay, so I wanted to just showcase, the differences again, so that when we get into the clinical stuff, people understand if you want to really maximize the regenerative potential. I'm not saying that fixed angle devices don't work. If you use PRF and you produce it on a fixed angle device, you'll definitely find improvements. It's just when you want to get this to work better, and if you don't have a centrifuge and you're thinking of buying one, always, always, always get a horizontal one because they'll work a lot more effectively. So this is on another website too, and it just explains the difference between both. Larger radius, higher RCF, shorter spin time. Tube centrifuge and a horizontal centrifuge experience a larger radius, resulting in a higher RCF and more efficient forces. Higher G-force produce a better seal with the tube wall. Due to better gel packing, the time required for complete centrifugation is only 2/3 of the time required on a fixed angle device. And that's just very simple math. So what happens is when that tube goes completely horizontally, the G-force at the end of the tube is a lot bigger, and you can actually do your spin cycles a lot faster. And what people don't realize is that, it's not just you might save 5 minutes between the differences here. The biggest difference is that always remember when you're spinning PRF, you're trying to separate these cells before clotting occurs because you're not using anticoagulants. And so when you actually can shorten the spin cycles and the G-force is higher on a horizontal one, you can get your layer separated more efficiently faster before the actual clot will form. And that's another major advantage of going horizontal here. Okay. And if you look at Eppendorf, and for those that work in a research lab, I'm sure you've seen a lot of Eppendorf equipment. It's the largest centrifugation company in the world. If you want to separate anything based on a gradient or density, gradient centrifugation definitely requires a swing out bucket. Okay. So that the horizontal layers can form that remain in that position at the end of the cycle. Okay. So there's major advantages of why, we always spin in horizontal. And since the year about 2018, that's all we've taught, and that's all, we've taught in our courses. It's also the reason why those papers that we've published on horizontal centrifugation have been the most cited in the field, and reason why, myself and a lot of our colleagues are ranked at the very top when it comes to academic ranking for research articles written on this field. Okay, so now that we have this technology, I'm going to talk about what we can do in extraction sites, and more importantly, we're going to talk about a lot of the systematic reviews that were written on the topics. And we'll go through basically the book that I wrote, Understanding Platelet-Rich Fibrin, through section by section, and talk about clinically how we use this product. It's very important to understand that PRF is not a miracle product. So it's not something that, I'm going to sit here and say that works for everything and you can use it by itself for all these different, it's very important that when we do clinical procedures on real human beings, that everything is as evidence-based as possible. So when it comes to extraction sites, one of the things that has been generally found is that, of course, we can, compress these. So if we take a full-size PRF membrane with this many cells, we can compress them and get them more densely populated. This is what we use for extraction sites, and we'll use as many as we can in an extraction site. When we do this, PRF can be left exposed in the oral cavity. So that's been known for many years, and you can do cross sutures, etc. In the case where you use PRF alone, always remember that the turnover is relatively rapid. And so in these cases here, we want to place these implants typically after 3-4 weeks. One of the major things, and I don't know exactly, and I should have probably asked just in Greece, what is more common if you guys use allografts or other biomaterials, because like in Switzerland, when I lived there, we were not allowed to use allografts. But in the United States, generally speaking, a lot of the literature shows if you use a bone graft, and especially an allograft, you can maintain this ridge a little bit more effectively. So most commonly, we recommend mixing the PRF with a bone graft. It'll hold the volume a little bit more stable over time. And then you can use either a PTFE membrane, PRF, or a collagen membrane for the soft tissue. Okay. And that's typically how we do that. So again, with extraction sites, you can use PRF alone. Your ridge will shrink typically 1.5 to 2 millimeters, which is quite a lot. If you use a bone graft and allograft, it might reduce by about 0.5, and that's what the systematic reviews have shown. In sinus grafting, there's defined rules here as well. And for this, we'll typically make the sticky bone. So we showed how that was done last course. And this is kind of the consistency that you want to create when you're going to be using sticky bone. And the nice thing about using platelet-rich fibrin, especially we use membranes with liquid PRF, is that if I put that in a sinus, especially a lateral approach, I don't have to worry as much about the particles going a little bit everywhere. So the nice thing is it makes the surgical procedures a little bit easier. It's nice to work with, and the graft material is dramatically improved. When we do sinus lift with PRF, there's a few rules of thumb. If we have not perforated the Schneiderian membrane, we typically put 2 PRF membranes on the Schneiderian membrane. And what we're trying to do here is just basically use PRF, number one, to protect the bone graft from banging up against the Schneiderian membrane. So remember that this membrane is typically 0.3 to 0.8 millimeters in thickness. And so if we have a nice little protective barrier, that's one of the advantages. The one that I find more important is that if I put PRF on the Schneiderian membrane, this whole area is like a dome now, where I have these vascularization proteins that are now over top of this grafting procedure. And since the Schneiderian membrane is typically in a low vascularization area, there's really an advantage of doing this. Okay, then the bone graft goes in. And then typically we'll use collagen over top of that, the opening here. So if there is a case where we do have a larger tear, we'll use collagen for the Schneiderian membrane. And I give a lot of credit to one of my close colleagues here, Dr. Michael Picos, and I know he's obviously has Greek descent. In his cases, when he's doing these types of sinus grafting procedures, the bone biomaterial utilized here, again, if there's a perforation, he'll use a collagen membrane, the bone graft complex here. That will be a mixture of allograft and xenograft mixed in a 50-50 ratio. And the allograft is supporting more new bone formation. The xenograft is holding volume. When you have that, we typically mix that 50% with cut up PRF membranes. And the advantage of this is you can help this tissue get revascularized faster. It will help slightly with new bone formation. And I'm very careful with the choice of words here, because when you look at the evidence for how much PRF is going to improve new bone formation, it's very limited. It's much better for soft tissue than it is for bone. But in an area like the sinus, which is already pretty avascular compared to other areas, you know, there's advantages there. And then on top of that, you can use less biomaterial. So one of the things that Dr. Picos mentions in the courses is that when you mix this together, like I said, you can use less allograft and xenograft. This will hold a lot of the volume, help with, you know, the vascularization, et cetera. So that's how that's mixed. Implants are going in here and then you close up. So that's typically how it's grafted. And I hope some of you guys have had the opportunity to read this book. It's called Bone Augmentation Implant Dentistry. It's probably the best book I've ever personally read when it comes to bone grafting. And it's about 200-300 pages and has over 2,000 clinical photos, step-by-step, how to do a lot of these more advanced procedures. Now, some people will use, turn off the volume, PRF alone for sinus grafting cases. And you'll see more and more people doing this. The one thing about doing this, number one, is if you're going to attempt this, make sure you have a lot of experience with PRF, first of all, in the first place. The other area that was discussed, which I think is even more clinically relevant, was that PRF alone should only be used in very narrow sinuses. And what this meant was that whenever you looked on a CBCT and you looked at the, buccal to palatal distance, that should be 10 millimeters or less. So very narrow sinuses where you'd use PRF alone. Most sinuses are much wider than that. And when you have a wider sinus, we always recommend to use that allograft xenograft complex, okay, just to be a little bit safer and more predictable in your outcomes. In the implant dentistry world, this is the one place where I thought PRF was most valuable. And when you look at osseointegration of implants, of course, the implants themselves can integrate into hard tissue, and they're very effectively doing so. So every major large implant brand today has great success rates with implants, and they've really optimized the surfaces of these dental implants to make sure they integrate into the body. The one place where there has been some issues is related to soft tissue. And we see a lot more issues in immediate implant dentistry. So I'll just give you a little story about myself, because I have practiced dentistry in a number of different countries. When I was in Switzerland, everything was a lot more conservative. People were delaying a lot more implants. People accepted delayed implants a lot more. So we call this early implant placement according to the ITI treatment guidelines. In the United States, it's not like that at all. In the United States, everybody wants things done yesterday, is what we say. Patients are a lot less patient. They're not as friendly, for sure. And they want, like I said, things need to be done right away. And so a lot more people do immediate implants in US versus in Europe. But when you place an immediate dental implant, it comes with a lot greater risk. And this is something that we try and educate all of our perio residents or oral surgeons, or, when we teach PRF courses, we try and explain this to dentists that there's a greater risk of immediate implants when you look at immediate implant dentistry versus delaying these implants. And what I always try and tell people is that if you look at, for instance, a lower molar, so let's say I extract, the most common tooth that's extracted is a lower first molar. When you take that tooth out, the defect is typically 10 millimeters in size. And in general, we'll recommend placing a 5-6 millimeter implant there. Well, if you place a 6 millimeter implant in a 10 millimeter hole, there's 4 millimeters that's missing there. And there's typically 2 millimeters a little bit everywhere. And what we find in North America is that every single clinician will agree that an allograft is the choice that a lot of people like to use for the bone. But for soft tissue, you'll have many, many different answers with what should be done here. And so a lot of clinicians will try and, bury the implants or use larger healing abutments or use collagen. Some clinicians recommend you should always do connective tissue grafting, or there's just a number of different things, and clinicians cannot agree on what to do with soft tissue. And I always tell the residents, I tell them, look, if you place an implant today and it's delayed, so let's say I extract the tooth, I graft, I wait 3-4 months, and then I go back in. The nice thing is that I have a full ridge. When I place that dental implant, only the roughened portion of the implant, which is, attractive to bacteria, is going into the bone. So it's it's a very safe procedure, because that dental implant, especially if I use tissue level implants, the roughened portion goes into bone, the tissue level is, extended above bone, and bacteria, they want to attach to the roughened portion of the implant, but they can't do it because that portion is buried into bone. And even if you place a bone level implant, you're always placing these implants subcrestal or at the crest. So the roughened portion of the implant is into bone or below it. When you go immediate, the problem now is that you're trying to engage this implant into the furcation area. The upper part of the implant is completely, the roughened portion is exposed to bone. Typically, people are using bone level implants. They place them, and this whole portion here, there's nothing there. And so even if you use a larger healing abutment and you try and get primary closure, so to speak, and tighten everything up as much as you can, the reality is bacteria are only microns in size. So these bacteria can easily float down here, go through, let's say, your healing abutment down in here. And when they get in this area, this is a place where bacteria just love, because they can just go attach to the roughened portion of the implant. And I always tell the perio residents, if this happens, congratulations, you just started periimplantitis, because those bacteria are very hard to get rid of afterwards. And so one French colleague by the name of Dr. Simon Pierre came up with one of these techniques here. And his cases were shown in the first version of the book, where he used PRF just around, the implant healing abutments. And the goal here was, when these implants were placed, okay, you always use one PRF membrane here and basically just sandwich that around the opening here. And that makes a lot of sense, because when that healing abutment is placed inside there and you have this big slimy PRF there now that bacteria, let's say I didn't use PRF here, well, that bacteria, even if I got primary closure, like I said, bacteria are microns in size. They can squeeze through tiny little openings, go down in there to the roughened portion of the implant surface. Periimplantitis just started. When you utilize this technique, which makes a lot of sense, now all of a sudden bacteria cannot squeeze in there, because you got this slimy PRF stuff a little bit everywhere. This, to me, is probably in dentistry the #1 place where PRF should be utilized, because we know PRF is better for soft tissue than it is for bone. We know periimplantitis is a big problem, and in these cases here, you only need one PRF membrane will do this job. One PRF membrane, you do this, bacteria does not want to land anywhere around here anymore. In fact, a bacteria would much prefer to land over here on the soft tissue than to land over here on this PRF membrane, where there's a lot more leukocytes, etc., that are there. So this technique here, like I said, is a great one. For those that don't use PRF, this is the first place we teach clinicians where to use platelet-rich fibrin, just around these implants, the healing abutments, put some sutures there. And again, it really helps with the soft tissue healing. Okay, so these techniques here, that's the gentleman there that's done a lot of the original cases with PRF. Great, great, great technique where you can leave PRF exposed to the oral cavity. Doesn't have to be beautiful. Put on the provisionals, the slime balls there. And then when you look at the healing after a few days, it's always significantly improved. Okay, so I always give these guys credits, the surgeons that have done a lot of these first cases, because the work that they did many years ago has been great. In the gingival recession field, the person that's credited with having done a lot of these cases is Dr. Alum, and he's a gentleman that lives in California. And what he started to show was that, of course, if you needed connective tissue, you needed to get a connective tissue graft. But if in the cases where there was a band of keratinized tissue, in those cases there, you can use platelet-rich fibrin as a substitute instead of using collagen for a lot of these cases, and it would help basically improve attachment and also help with healing. So these were techniques that are a little bit more advanced, but the step-by-steps are well explained in the textbook, where you can utilize platelet-rich fibrins for such cases. Now, the rule of thumb here, always remember, you need a band of 2 millimeters of keratinized tissue, okay? So these are not cases, if there's missing keratinized tissue, you absolutely need to get a connective tissue graft, and for that, you go to the palate. And the reason why you do that, when we explain this to clinicians, always remember, when Professor Carring did the first studies in this field, the goal was to go to the palate, get keratinocytes, because if this doesn't have any more keratinized tissue, the problem is you don't have the cells that make that tissue, which is keratinocytes. And there are absolutely no keratinocytes in platelet-rich fibrin. So if you're missing those cells, you can't take PRF alone and expect that somehow this is going to magically work out. In those cases there, you need to find those cells, and to find them, you got to go to the palate, you take out keratinized tissue, they have keratinocytes in there, and you bring them and transplant them to the new area. Okay, so that's why we use connective tissue grafts. But in these cases here, where you do have a band of keratinized tissue, and ideally the rule of thumb is a 2 millimeter band of keratinized tissue, you can very easily create vestibular incisions, as they've done here, full thickness flaps with the PRF in there, and these lead to quite predictable results. For intrabony defects, this is an area where I do a lot of work in, and I'll show you some of the work that I do with Dr. Estrin, another periodontist that works in our dental practice. And originally, when these were first started, Dr. Mealy has done a lot of these cases in San Antonio, where when you had a narrow intrabony defect, they were using a lot of demineralized allograft here. And in this randomized study, they compared DFDBA, so the demineralized allograft, to PRF. And what they did, they took a full-size PRF membrane, cut it up into small pieces, used it here, suture this closed, and sure enough, this led to the same clinical attachment levels as did DFDBA. So those were all randomized studies that were previously done. And a lot of work has been done in this field over the years. So when you look at the studies, and using platelet-rich fibrin, the two fields where PRF is most studied: one, intrabony defect regeneration; two, gingival recessions. And there's really defined criteria. So like I said, for those that are periodontists or that do these procedures that want to learn more, I highly recommend reading the textbook, because all the literature is very, very well defined. There's been over 30 or 40 randomized studies comparing open flap debridement versus PRF, for instance, or different groups like DFDBA versus PRF. And what you routinely see is, when you look at pocket depth reduction and cal gains, significantly better with the platelet-rich fibrin. When you compare DFDBA to PRF, look at the pocket depth reductions, about the same. Clinical attachment gain, the same, no difference between the groups, okay? And there's a lot of studies in this field. Like I said, look at all the studies year by year. And again, when you look at PRF versus DFDBA, this was the study that was done in San Antonio. No difference in the pocket depth reduction, no difference in the clinical attachment gains, no difference between the groups. So that's an area where we can, instruct clinicians. You can save a little bit of money here by not using DFDBA and going more towards PRF for the narrow intrabony defects. And that's the study. This was a very important study because it was done at a very respected group, and that's in San Antonio. And San Antonio is well known in North America for having done the first studies on bone allografts. So very nice outcomes here that you find, and you guys can read those papers if you're interested. This is more recent. So since the year 2019, more and more colleagues are trying to do less invasive surgery. So what this group at Harvard did was they looked at a proof of concept study, non-surgical periodontal therapy. What they wanted to do was develop a non-invasive use of PRF with periodontal therapy. And what they were doing was they were doing regular SRP, but in the test group, they were adding platelet-rich fibrin. So you'll see here, it was a split mouth study. The test sites received PRF as an adjunct to scaling and root planning, while the randomly inside control sites received scaling and root planning only. And what they found was PRF, when applied together with scaling and root planning, resulted in significantly more pocket reduction. So you got an extra millimeter here, 2.53 versus 1.46. Higher cal gains, 2.41 versus 0.84, an extra 2.41 versus 0.85, so an extra millimeter and a half, and less gingival recession. Okay, so the way that this was done, and this is one of the videos from one of our textbooks here, a lot of times we'll clean out with erbium YAG here, which I'll show a little bit later, some videos of Dr. Estrin doing that, where we'll take PRF, we'll cut it up into small pieces. And when we have a full-size PRF membrane, we always use the bottom of the membranes here. Okay, so that's another thing that we do. And then we'll go ahead and tuck those into the pockets. Okay, so that's a nice little application of PRF. A lot of the times here, you do not need sutures, so this can be tucked in, and you'll find this video in our textbook from one of our co-authors. Okay. Now, when we actually do these types of cases, every once in a while when we use lasers, you'll see very nice outcomes. Now, this is not all the time, of course, where we can generate this kind of, new attachment, but you'd be surprised that it's quite nice to learn that you can actually have this happen without any type of surgery. So on average, we'll get an extra millimeter from laser, an extra millimeter from PRF. Every once in a while, you get many millimeters together. And before we ever attempt surgery, we always try and use this combination approach with lasers and with platelet-rich fibrin. So it's something we do frequently. In North America, I don't know if these are used out in Greece or not, but Arrestin is very commonly utilized. And what Arrestin is it's an antibiotic, 1 milligram, and it has a slow and gradual delivery system, so the antibiotic can be delivered over time. And the problem with things like this is you get the benefit of putting antibiotics in the pockets, but a lot of these delivery systems are polymers, which are inflammatory to your immune system. So if you think of a general periodontal pocket, it is inflammatory. There's a lot of immune cells. Those immune cells are not happy. And while it may be advantageous to add antibiotics there, the problem is that we're putting polymers in different types of chemicals or biomaterials, which may further cause inflammation for our immune system. And the advantage of doing that is that you can slowly deliver antibiotics over the next 2 to 3 weeks. And when you think of platelet-rich fibrin, since it lasts 2 to 3 weeks, we can use PRF as a delivery system for this instead of using these chemicals. So these are typically, $30 to load minocycline into the Arrestin. We'll do the same thing, whether it be with that or chlorhexidine with PerioChip. These are different products that are available here in the United States. What we typically do is we will mix minocycline with the PRF, and we do it this way here. So we'll take, for instance, this is 10 milligrams of minocycline. We tell the pharmacist, please compound this and make this for us in the smallest liquid possible, because I don't want to dilute my PRF. So he makes us, in this case here, 10 milligrams, and you'll see with Arrestin, it's 1 milligram. So what I've done is that was enough for 10 pockets. So if I have a patient that has 10 intrabony defects, I'll tell my pharmacist, make me 10 milligrams in the smallest liquid dose possible. I'll mix that with my PRF, and then I'll go to my pockets and I'll place those in my pockets. And that's research that we're doing here with Dr. Estrin. So that's a close colleague of mine. And with Dr. Estrin, what we try and do is, instead of just doing scaling and root planing, which a lot of people do for maintenance of periodontal patients, we use a lot more advanced technology where we use a lot of lasers. We'll add PRF to the pockets as well. And we're currently doing research where we take PRF and we mix it with antibiotics. And these are research projects that are currently underway in our office. So there's Dr. Estrin here, and he and I have been looking at specifically 6 different groups in our randomized study. So we have regular SRP. These 6 groups we actually do in every patient. So we find a patient that has a lot of intrabony defects. One intrabony defect we treat with SRP alone, another one with SRP plus lasers, lasers plus Emdogain, lasers plus PRF, lasers plus PRF plus minocycline, lasers plus Arrestin. And we're figuring out which of these groups is most effective in order to develop future protocols for the future. So another way we can do this, which may be a little easier, that's the minocycline right here. So here I am. Here, I'll just take out the volume. But what you can do here is just add a small amount of liquid depending on what you're doing. So for instance, if you're treating 4 pockets, we'll add 4 milligrams of minocycline. We'll take our standard liquid PRF here that was spun in the horizontal centrifuges, and we'll take that liquid and basically allow it to clot with the minocycline. And then what we have is these little clots that are then formed that contain the antibiotics, and then we'll bring that to the defect. So this is another way to do it as well. Okay, so you'll see here, we'll just mix up the liquid PRF. And again, we're spinning here on a horizontal system to make sure that we get as many of the platelets and leukocytes as possible, especially the leukocytes when we're treating any type of infection. Okay, and we'll just wait for that to clot. So there it is setting there. I just give it a little mix, and then I'll let it set there. After about 5-10 minutes, that will entirely clot. And then what you see here is we have a full-size membrane, and then I can cut that up into small pieces. And what we'll do is we'll bring that directly to the pocket. So we can cut them out whatever sizes we need, and we'll put some of that in the pockets. So we do these routinely. Here you can see lasers treating these intrabony defects. That's Arrestin right there. And then we'll put PRF in the pockets as well. We actually teach courses on how to do that. Okay. Did I keep this in here? No, I'm going to skip over this part here just because I already showed the tube stuff. I wanted to talk more specifically on the Alb-PRF as well. The Alb-PRF is a newer technology that's been around for about 6 or 7 years, used alone. So when people will say that this is potentially not safe, etc., this has been used to treat thousands, if not millions of patients by now. And originally it was invented by a group in Russia and Japan in 2014. And what they showed was that by heating albumin, especially, that's the main protein found in blood, it would denature albumin. And then when you take that and you put that into the body, it lasts a lot longer. That was the main advantage, was we could extend the working properties of PRF. So people started to use these as facial fillers with no growth factors. They would just take platelet poor plasma, heat it. That's been done for many, many years. The one thing that more recently we've been interested in doing, and this was first, our papers from 2019, we would spin the blood the same way, but instead of just taking the PPP and heat it, we said, why not add to that the liquid growth factors from the buffy coat, mix that back in, and that's what we call Alb-PRF. So what this is it's a heated version of plasma. It contains all of the growth factors as well that you would typically find in platelet-rich fibrin. And then we started doing many studies with this. So of course, when you want to characterize how long this biomaterial will last, we do what's called ISO 10993. So this is a test that's required by the FDA to determine how long biomaterials last. And the way that it works, so let's say a company tells you our barrier membrane lasts 8 weeks. The way that that's figured out is you take a collagen membrane that you would use in dentistry, you use this exact same model, you place the biomaterial subcutaneously, so under the skin of the animal, and then every 2 weeks you go back in and see how long this biomaterial takes to break down. And in this animal, what we've done here in this group of animals, actually, one side has PRF alone, and you can see it's gone after 2 weeks. On this side is the albumin PRF. And this will last about 4 to 6 months. Okay, so after about 4 months, it's really starting to break down. At most, it'll last 6 months. And we've since learned that when we use it in facial aesthetics, there's different areas where it breaks down a little faster or slower, depending on where we use it, just like Juvederm and other biomaterials. But this is fully biocompatible. There's not a single chemical here. You can see that the body will grow vessels around it. It is cell occlusive, so you can use it as a barrier. And I'll show cases of Dr. Picos using that in dentistry, as well as some of our periodontists in our office. So the way that this is done you draw up the upper liquid plasma layer and you heat that. And once that's heated, the albumin is denatured and it looks like this. So it's denatured albumin. I'm going to take that denatured albumin and I'm going to mix it back together with the liquid PRF. And when we mix this back and forth, what we've created now is our standard albumin gel that's been utilized for, almost a decade now, but now it's got all the growth factors inside of it. And we call that Alb-PRF. We personally call it simply extended PRF to our patients. Or in the facial field, we call it biofillers for biological fillers. And then we can inject it. It looks very different than normal liquid PRF. And that's what we use in a lot of our patients. Okay. So personally, I've injected, thousands, literally thousands of patients with this. It's been utilized in our practices. And with a lot of our care aesthetic practices, we have done probably 10, 15,000 patients 100% naturally with these biological fillers. And we inject this the same way as we would a normal filler, but the difference is now we have no chemicals. We don't have to pay the fees that we would pay for Juvederm and some of these other products. And on top of that, it goes away every 4 to 6 months, just like Botox does. So instead of these patients going in for Botox every 4 to 6 months, we can do these all natural regenerative procedures. And a patient like this, we treated her with lasers and PRF. So it's work that we do routinely. In the dental field, what we first started to do was create these membranes, and we were using these. This was done in Bern here back in 2019 when Misako and I first started to use this in oral maxillofacial surgery. And people that were coming in with, especially over titanium meshes, which have a high rate of exposure, we can utilize this technology to try and decrease the rate of titanium mesh exposure. I'll show you today how Dr. Picos has been using it for full arch cases, okay? Today we have these custom trays. So when you get a BioHeat kit, it'll come with these trays where we can make different shapes and sizes. So this is for horizontal or large procedures, diabetics, their defects are typically circular extraction sites. You can use it for a lot of different procedures. And this is what I showed, the other week, where this right here, we call this the BioBone protocol. And what this is you'll see here, that's the albumin gel that's been heated. And to that, there's a sticky bone right here. So what this is instead of just making your standard sticky bone, to the sticky bone, you have an outer layer here, which is the albumin PRF, where you can go to a ridge and just literally put that on the ridge. The sticky bone is on the ridge, and you already have your collagen membrane essentially built into it. So instead of the collagen, you're using this heated stuff, which will last 4 to 6 months, okay? And that's been utilized again in many, many different cases. The way that this is made is when we heat the plasma on a tray. So if we have the tray here, we actually take the albumin gel, put it at the bottom of the tray, flatten it down, create a little 1 to 2 millimeter thick membrane. Over top of that, we place, our bone grafts or allograft, add the liquid PRF, wait for it to clot. Then when we take this all out, we have the albumin gel, the heated stuff here, and our sticky bone here. And then we can go to a ridge and use that. So, with Dr. Picos, the great thing about all of his clinical expertise is that he's been utilizing a lot of these procedures for a number of years. So he's been utilizing a lot of these techniques, and he's really big into zygomatic cases today, where he's teaching some courses. And, he's used and done comparative studies where he's compared buccal fat pads covering these to the BioHeat technology. And so when you have cases like this, with extensive resorption in the sinus, especially, you can't really do sinus grafting procedures. A lot of the clinicians prefer to go zygomatic implants here. When you do this, of course, there's a lot of exposure of these implants here. They need to be covered. And what he's been doing routinely is creating the BioHeat, using that to cover these zygomatic implants. And like I said, there's not too many cases in dentistry that are bigger than these ones here. I mean, these are very big cases to do. And then covering that up. And of course, these patients heal real nicely. You can see the post-op, the healing, and they react very, very well. So that's after the procedures there, and been utilizing that. If anybody wants to learn how he does those types of cases, I recommend you go to Tampa, Florida, more specifically Trinity. You can always fly in there. He has a lot of Greek people that will fly all the way to Florida to take his courses. He's probably one of the best oral surgeons in the implant dentistry field. In the facial aesthetic field, we've done a lot of work in the PRF space. And the reason why is because it's just a more natural way to regenerate facial tissues. And it's a really booming field, especially in areas like Florida and California, as you can imagine. As dentists, we're allowed to do these procedures here in North America. So for us, we're allowed to treat from, kind of the neck upwards. And these are very easy procedures to do. There's a lot of money in this field. People want to look younger and they want to look better. And as dentists, we're taught to really focus on aesthetics. So when you look at somebody's physical attractiveness of their face, most commonly reported is the person's smile, teeth. This area here is really important for aesthetics. So, when we do that work on a day-to-day basis, we can always do the rest of the face. And this is a fun field to work in. I like to show people that in North America, the dental implant market is a $4.6 billion a year field, growing at 9% per year. All of dentistry is 25 billion, growing at 6% per year. So if you do implants, it's a bigger field than dentistry as a whole. It's growing faster, so to speak, and it's 5 billion out of 25 billion. So it's about 20% of all dentistry, but it's growing at a faster rate, 9% versus 6.7. When you look at facial aesthetics, it's already a $31 billion a year market, going to 119 billion and growing at 21% per year. Okay, so apologies for that. It's a huge field. And actually, let me go back here. When you look at where the future is going, it's growing very, very rapidly. So you can see here, facial aesthetics, implants. The facial field is more than 20 times bigger than implant dentistry. Okay, so that's something that, so apologies for that. I'm just in the office. So this book right here was written by Dr. Davies. Sorry, guys. Okay, I'm just going to keep going. So the book was written by Dr. Davies, and it's got 12 chapters. If you want a copy of this, you can get it directly from Quintessence. So in Germany, that's where the main headquarters is. And the book covers all the injection techniques related to this. All right, much better. So this was written by Catherine Davies. Okay, sorry about that. It was just a technical issue. So this book right here, like I said, was written in facial aesthetics. Amazingly, out of all the books that I've written, this is the most sold textbook out of all of them. And it was quite surprising for us because, like I said, I wrote the first version of PRF book. I wrote a biomaterial book. I wrote the facial aesthetic book. I wrote a book with Dr. Picos. And assuming that, PRF as a whole would be a much bigger book than just the small component of facial aesthetic, we were completely wrong. And this book outsold every single book. and today is a bestseller. I'm always surprised. Like I said, I just found out from Quintessence, even in 2022, it was written in 2019. It's the second most sold textbook in the world in 2022 so far in the first 2 months. And Quintessence calls me all the time and they say, Rick, you know, this facial book is just completely dominating every other one of your books. There's a lot of great textbooks written on GBR and other things. This is a unique book, one of its kind. There's no other textbook that's available talking about these all natural therapies. We do a lot in the practice with lasers and platelet-rich fibrin. Okay, so it's something that we do a lot of. Now, in this space here, the nice thing about working as a dentist in this space here is that we can do these procedures, everything, and our assistants can do a big portion of this. So in order for a dental assistant to do a lot of these procedures like microneedling, they need to get a tattoo license. And it's interesting. So the whole field itself, when you look at microneedling, it actually started with a tattoo story. So there was an African-American lady. They had a big scar on her face. And unfortunately for African-Americans or black-skinned people, they actually scar white. And when somebody scars white like that, it looks very visible. It doesn't look good whatsoever. And for these African-American people, like I said, this lady, she didn't like it at all. So she went into her plastic surgeon and said, look, we got to do something. He's like, I tried to reproximate the lines. It's still white. We can't really do anything. And they decided to actually start literally tattooing black ink into the skin. So this African-American person started to get black ink into the skin. And in her case, what they decided to do was just tattoo. And a week later, when she went back in to visit her plastic surgeon, everything was smooth. Everything looked good. She was blown away. The plastic surgeon was like, man, this tattooing, this needling actually, you know, fixed all your problems. And so what he then did was he took literally a needle and he started needling, you know, one after the other into the skin with just the tattoo gun with no ink, and did a case series with that. And everybody ended up improving the skin texture. And that's when microneedling was invented. So what microneedling is it's a little pen that has 12 little needles, and it's going to do this over and over and over again. And it first started with scar victims, so they would improve scars. And then it went towards wrinkles. So people started to use it for wrinkles as well to look younger. And then people started to use it with like hyaluronic acid or PRP, which is called vampire facials. And today they use PRF. So this is a technique that can entirely be done by my assistants. And what my assistants need is actually a tattoo license. When they get a tattoo license, and if you get a tattoo, you take a needle, you go into the skin 1.5 millimeters, you deposit ink, and you do this over and over. In those cases there, what they're going to do is they're going to tattoo into the skin PRF, right? So instead of going in and putting ink, you're going in and you're just putting PRF. And this is something that's a very popular procedure in North America, mainly because Kim Kardashian, who's, you know, a celebrity, so to speak, out here, started showing how this works. So this is a nice little video, and it shows what microneedling is. So this lady is a YouTube, you know, social media celebrity. These videos have been watched millions of times. And I always say, when I watch these videos that have been watched that many times, there's been that many females that have literally sat and watched this type of video over and over and over again online. And that's in our dental practice, for instance, when these videos have been watched a million times, there is a lot of females that want these procedures done. And so that's the reason why we offer them in our practices. And it's one of the reasons why we teach and highly, highly, highly recommend that people offer these types of procedures in their practices. So in the video, you're going to see she's doing this at home. So she's going to use hyaluronic acid. We don't use hyaluronic acid very frequently because we prefer to use PRF. The wound healing's better. She's not using topical cream. So we'll always, as doctors, we can apply topical to make sure they're completely numb. And we're going to do this procedure, like I said, by pushing the PRF into the skin. So what they do, this is your skin. You're going to apply PRF on the skin. You're going to push the PRF into the skin, the same depth as you would put ink into the skin, just like a tattoo, but now you're going to push the platelet-rich fibrin into the skin, and that's how that's done. Okay, so we'll watch the video here.
absolutely sterile needle. I always show people that it's still sealed in the package, not that anybody would ever think I'd reuse needles, but yeah, that's just super important. This will get used on my skin today and it'll get put in a sharps container and disposed of. So that's super, super important. Sanitation is huge with this, you guys, because obviously you're sticking needles in your face. So I'm going to cleanse my face, and I am actually going to swab my entire face with alcohol again, because it's so important that there's nothing on my face as far as makeup, sunscreen, moisturizer, none of that stuff. So what I'm going to actually needle into my face today is hyaluronic acid, my medium weight pure hyaluronic acid. I happen to love it. Okay, here I am once again with my fabulous hairdo and, you know, the whole nine. Completely clean skin, and I've taken an alcohol wipe and finished that off. Here I have, again, my hyaluronic acid. So the way that I microneedle is I have a pretty planned out. I'm going to start here, and I can dial up the millimeters that I want here. So that's pretty awesome. Now I'm going to start over here, and I'm going to do about a square inch, and I go down, across, and then diagonal through that square, and then I move on. This ensures that I get everywhere. I'm going to get pink. I might get some pinpoint bleeding, and I'm going to have to keep applying my hyaluronic acid. And because I'm using HA, I'm choosing to also use water because I want to drive the water and the hyaluronic acid into my skin. Now you can see, you guys, I'm surviving this. Does it hurt? It doesn't feel like a party, but it's totally tolerable. I have not used any numbing. When I get close to the eyes, I stamp a little. I don't grab. Depending on your practitioner, some like to get a lot of bleeding. I am not of that philosophy, but that's a personal choice of the practitioner. I feel like some nice flushing, maybe a tiny bit of pinpoint bleeding, and that's fine. That's good to go. Good results will happen. And I didn't have to, you know, hamburger up somebody's face. Today, I'm going to be like I'm sunburned. Tomorrow, I will wake up with the most amazingly glowy, fabulous skin. It is the perfect date night procedure if you do it the day before. So because I'm inducing all of this collagen, you guys, it's shocking how within about a week to 10 days you can start to see something happening, and that by 4 weeks you really can start to see, and you know, your collagen continues to be produced for up to 6 months from the microneedling, so you're going to continue to see benefits for up to 6 months. If you do a series of 3 or more about a month apart, it is incredible, the anti-aging benefits.
Okay, so there's a lot of things and points that she made in that video which were quite useful. So you can tell, first of all, that's a mid-40-year-old lady. She's got great skin, and you can tell she's really involved in that space. I wish I could take this actually off. In her case, here, give me a second here. I'm going to unplug this. All right, I just unplugged it. In those cases there, like I said, when you do the microneedling, she said if you do a series of 3 or more treatments, it's incredible the anti-aging effect. So that's exactly what we do. We do 3 treatments, Every one we do 1 month apart. And, she even made a joke, if you do it, the day before a date night, um, it's kind of funny that she said that, but it only takes about 1 day for healing to occur. So we can do these treatments. 1 day later, our females look, kind of their best, so to speak. And many people will come in like right before, a wedding or anything like that, to get these treatments done. So, um, these are just some of the figures from our textbook where you can look at the skin thickness. You almost get the illusion that these are different magnifications, but they're not. This is just normal skin, and that's your epidermal layer and your dermis layer. This is how much thicker it gets when you do the microneedling. So when you look at patients like this, and this is from our textbook and with collaboration with the Dermapen company, it's amazing how you can fill these wrinkles, and use this technology for these types of applications. So that's the simplest thing you can do in your practice for facial aesthetics. It's very easy to do. And like I said, our dental assistants do these. So these are not even things that our doctor needs to do. Either a dental assistant can do it with a tattoo license, or you hire a medical esthetician, and an esthetician can do these procedures. It's also great for treating things like acne. So if you look at acne in general, in these cases here, this right here obviously is an infection. And in a case like this, you can actually push leukocytes, the white blood cells, into the skin and help healing occur here. So that's another thing that you can do in those cases there. These are great before and after pictures, but quite honestly, these are very, very easy treatments to do. And we do these treatments all the time. It's routine in our practice. Another case here where you look at somebody that has acne, and this is a very, I don't want to say aggressive case, but, in a young person like this, that's a teenager, for a young teenage female, this is the end of the world, so to speak, right? They don't want to go outside. They think they're very dirty. They don't want to go talk to friends and this and that. But there's really two options in North America for something like this. We can either put them on Accutane, which is a drug, or we can microneedle with platelet-rich fibrin. We'll do a lot of these treatments here with lasers, and that's kind of the final outcome here when we do three treatments 1 month apart. When it comes to injection techniques, this was written by Catherine Davies in the book, and she did a really nice job to illustrate what to be careful about, how to do these injections. In these cases here, like I said, the book was very, very well received. And like I said, it's been either a bestseller, top 2 seller every single year. And it's our most popular course, to be honest with you. When I first started teaching, I come from a background that's very basic research with biomaterials and growth factors in the dental space. And we're teaching PRF and dentists how to use PRF in daily practice. Our most sold out course every year is our facial aesthetic course by far. And the number of dentists doing these procedures today, and medical doctors and nurses and everybody from A to Z is taking these courses because it is a booming market, and many more dollars are in this space when compared to the dental space. So one thing that Kathy would always say was, when she would teach these injection techniques, dentists are by far the best injectors in the world. And when you think of the complexity of everything we do in dentistry with all the injections in the oral cavity, very, very easy to do facial injections where you can see full lighting, direct needles. You don't have to go inside somebody's mouth, on and on and on. These become very easy to do, and dentists are really skilled. So she teaches how to do a lot of these techniques. I'm not going to go through them, obviously. We also have some great educators in laser dentistry and laser facial aesthetics. So one of the things that Dr. Schiffman has done, who's also a professor at Nova part-time, is he developed a lot of protocols with lasers to regenerate facial tissues. And so if you look at female and aging, a lot of times the lower third of the face ages faster than anywhere else. So they find that their nasolabial folds get thickened faster, and marionette lines, on and on and on. In those cases there, like I said, it's just very easy to take a laser, and he goes intraorally. Actually, he was one of the first people to do that. So instead of shining the laser light this way, regenerating the tissue, he actually goes inside the mouth and regenerates the tissue that way. And there's many advantages to doing it that way there. And that's protocols that are all patented by Fotona with their smooth lace technology. But number one, the tissues heal a lot faster intraorally than extraorally. Number two, like if you use a laser for a Lanap procedure, so some of you guys may have heard of that in Greece, Lanap, laser assisted new attachment procedures for perio. In those cases there, the ND egg is regenerating PDL cells and fibroblasts. Well, you can shine the light the same way, this way here, and it'll help regenerate these fibroblasts. If you do the same thing intraorally, it actually works a little bit better because the tissue is much thinner. If you think of skin thickness on the outside of the mouth, so outside versus inside, it's a lot thinner inside, and that laser will penetrate much more effectively. And we give a lot of credit to Dr. Schiffman for all the work that he's done in that field there. And these are his cases. So the nice thing about these cases here is that you can tell a patient, look, if you don't want anybody to know that we did anything at all on you, we can do the whole treatment intraorally. Nobody will ever know. You'll never be red on your face. Nobody will ever know anything was done. And we can do that whole procedure for the lower third, and look at what a nice difference that is made there. Okay. So we do a lot of combination stuff with lasers, laser peels, microneedling, injections. Go through all the protocols, but I'll just kind of explain briefly what we do. This is the laser that's shining here on this patient here. I'm treating somebody with a nasolabial fold, and I put the laser in, and I'm going to shine the light directly on that tissue and try and regenerate those deeper nasolabial folds and marionette lines. And I'll show you how that's done. I got a couple little videos here. These are little marketing videos that we use for our office. These are literally 1-minute videos that I use around my clinic, about a 10-mile radius. They're just things that I've done in the office where we like to show people how we can, for instance, remove an H spot very easily in 40 seconds, or how I can treat nasolabial fold in 1-minute videos. So like I said, our clinic is called Esthetics, and it stands for the Center for Advanced Rejuvenation and Aesthetics. So watch this little video. I use it for marketing, but it actually explains to dentists and other people that don't know much about facial aesthetics how easy it is to remove age spots and do other treatments compared to how complex dentistry can be.
Even though it's far away, we're gonna put these on the patient just so you can see. Good. Okay. Here we go. You're gonna feel a little. Okay. Is that okay? Perfect. Okay, so we're just going to remove this. Okay, you can see the color's basically gone now. We're just going to flatten it out. Okay. Looking pretty good.
Okay, so those are just 1-minute ads we run. Like I said, you play that around your office and on an Instagram or Facebook ad, and you'll get tons of people coming in for consultations, and we meet them and we talk to them about their issues and we treat them. This is the smooth lace protocol that I was telling you about. So watch how easy this is, and any dentist can do this because it's all intraoral. So this is with the Fotona laser systems where we go intraorally to treat some of these nasolabial folds.
1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Close up. 1, 2.
Okay, I'll just pause here just to explain. So you can see exactly where the laser is firing. So you guys are doctors, obviously. I'm purposely looking at the upper part of the nasolabial fold, mid part, and the marionette line, and making sure the energy is delivered exactly in those spots in order to build the collagen in those areas. Okay, but again, these are very easy to do, and they work very, very nicely.
3, 4, 5, 6. Okay, lick. open up. Okay, again. Oh, got open. Okay, we go there. Marionette lines. And then we try and hit as high as we can go here. Close. Good. 1, 2, 3, 5, 6. Good.
Okay, so the laser is a nice technology and we use it all the time in combination with platelet-rich fibrin. I would say probably 95% of the procedures I do either in dentistry or in facial aesthetics involve both use of lasers and platelet-rich fibrin together. These are just some for dark circles, laser peels. I'm going to skip over those. But the way that we get to a lot of these outcomes that we show you, this is not just PRF. This is, we've gone intraorally on this lady. We regenerated all this area. We spent a lot of time with the laser intraorally to regenerate this. We've done microneedling with PRF to refreshen her skin. So that was basically the needling, like I'm giving somebody a tattoo, but with PRF. So we're putting that into her skin to give her better glow and smooth out the tone of her skin. We've also done injections in her temples. You can see she's lost a little volume here and here, which made her look a little older. We filled those a little bit, given her a little bit more bounce in her cheekbones here, and also injected down here in this area to treat kind of the aging that you see in the lower third here in combination with lasers. So that's, a lot of what we do today. And that's where, like I said, the biofiller especially is very, very useful and much more useful than just regular liquid PRF, which only lasts about a week. So, as we've done more and more of these procedures in facial aesthetics, we've noticed that the trends are going, at least in North America, more and more towards natural look. So 10 years ago, everybody here wanted to look fake and bigger lips and today, like I said, that looks pretty ugly and people want to look just like themselves, but 10, 15 years ago. And that's where I think PRF can be very helpful. Biofillers can be very helpful. They don't cost you a lot of money, so it's very cheap to do these procedures in your office. Of course, in different places in the world, you would charge different amounts for these types of procedures, but they're very nice. And we market no chemicals, no fillers, all natural regenerative sciences. And this, as the laser field gets better and as the PRF field gets better, and as we improve this, as we go more horizontal, as we go more with the biofillers and we learn more about these technologies, we can get better and better results with respect to this. This was our office when we first started. So we started setting up in our dental practice. You can see here, we're Lakewood Ranch Dental. This is the practice owner. We've got a big practice, 10,000 patients, and we can do, we do a lot of dentistry and we see a lot of patients, and there's 6 different doctors working there. I started doing the facial procedures on Mondays and Tuesdays, and, very quickly I got fully booked doing these. And we treat 10 to 15 patients every day. I've been doing it for about 3 years and, developed a lot of expertise in the field. And it's really nice to do these natural procedures. They're safer. I think they lead to better outcomes, quite honestly, when compare this to fillers and Botox, because they always look more natural and they're safer for us to do. So it's, the risk is lower. And we started doing that. I remember the days that we put up all the banners and we really wanted to focus on all natural. So we had the BioLift protocols and no chemicals, no fillers, did some laser stuff, microneedling with PRF, and talked about the packages that we offer, et cetera. So it's been a really nice field to work in. And for those that are dentists in other parts of the world, I encourage them to offer these procedures if you're allowed to, because they can be very profitable and they're a lot of fun. So patients, they don't come back to your practice upset, or, they're very excited, they're happy. It's a very different vibe than doing dentistry. All your assistants are much happier working with you when you do these procedures. So it's a lot of fun. I remember David Kowski is one of our educators. He was excited to do these procedures too. He said, what, Dr. Miron, I would like to have all your banners in my office to see, if I could do the same thing in my office. And I said, well, you've taken the courses, you're well trained, you're very good at lasers now, you're very good at your injections and your microneedling and everything else. So I gave him all the stuff ready to go. He just paid me for the banners and trifolders, and he started doing these. And now, he became Aesthetics Cleveland. So we basically started like a little grouping between dentists around United States that wanted to do these procedures. About 1.5 years ago, we started this, and today we have about 70 clinics all across the United States that are offering these all natural procedures. So these are all other dentists that for years were doing Botox, fillers, and other things, and today they want to go more natural. And we have a growing trend of dentists and colleagues that want to do these procedures, which is a lot of fun. As I mentioned to you, these are always our most sold out courses. This was actually last weekend. We were in California. We had 150 doctors. We typically offer 4 or 5 of these programs per year. There's never less than 100 people. We have 20 educators, and we teach how to do these procedures. If anybody's ever interested in coming, there's a course in Fort Lauderdale and there's some in California. And people come over, they learn how to do these things properly. They learn the biofillers, how to do them properly. I don't think there's any other group in the world that's even close to as advanced as ours. And, you know, these are procedures that are fun to learn. And even if you just want to learn them, to do them on yourselves and on your family and friends, you know, these are, you know, great procedures. And like I said, they're safe and they're all natural. So these are fun. And on the last day, what happens, there's me there with a group of doctors I'm working with. But, you know, what happens is we set up about 20, 30 aesthetic chairs in the room, and doctors are rotating around all day long. Every hour we rotate. In one station, they learn microneedling with PRF for an hour. When they get done with that, they go to another one and learn lip injections with PRF. When they're done with that, they go to another station. And we have, you know, basically 3 doctors per station doing just that all day. And you rotate around. You know, you're with lasers for an hour, you're with microneedling with PRF for an hour, biofiller injections for an hour, hair injections for an hour, lip injections for an hour, skin care for an hour, and you just rotate around all day learning all these things. So it's a really good learning experience. Even though there's 100 people, you're always in a group of about 6 people, and you get to learn in that little group, and you're rotating around all day long into different stations. So it's a lot of fun to take this course. This is to show people kind of the improvements that we can expect. So, you know, this is another patient that I treated, and interestingly about Nancy, I like the outcomes because she was a 7-year-old lady, and she kind of explains the process. So she didn't know very much about these procedures and using PRF or using lasers. It was one of her first treatments ever done in facial aesthetics. And we can show people, when we go all natural, the kind of outcomes and improvements that we can expect. And you'll see her even say in this video, so it's an actual video, this is a video that was recorded after she had 1 treatment and she already had some benefits. And she was already saying, you know, I'm hoping to get even better results. And then this is after 3 treatments. And that's not after the 3rd treatment. That's a couple of months after the last treatment, where always remember that these are regenerative protocols. So, you know, the day after the procedures, they got the growth factors in there that are going to slowly and gradually start to improve the skin over time. So we always take the last video about a month or 2 after the last treatment. So you'll see the little video here.
Hi, I'm Nancy, and I have had my 3 protocol series. I felt like my forehead was in good shape, but things were beginning to sag, and it was time to do something, and I did not want to go under the knife, that's for sure. So this is a nice, easy way to accomplish what I think is going to happen. All of those issues that I was concerned with when I came in here, I'm very satisfied and very happy with the end results. It was an interesting experience. I didn't know what to expect, to be honest with you. I knew it was going to be laser. I did not know we were going to go inside the mouth. I knew we were going to do some needling. I've just been really happy with the process from day 1 when it first happened. It was like, you don't know what's going to go on, but when you get through that first treatment, you kind of get an idea of what's happening. I will have to say the procedure was certainly tolerable. I didn't experience any particular, if you'll call it, discomfort or pain, if you will. And I'm sure there's different tolerations of pain, but you're doing it for beauty, you're doing it for an end result, so bottom line, it's all worth it, and it's not very long. So if you experience some discomfort, then you can get through it because it doesn't last very long. Your advertisement, first of all, caught my eye, and when I read more about it, it even got more interesting, particularly because it was a natural way to get younger looking skin, hopefully. I'm 72 years old, and I didn't want to look like a 30-year-old. I just want to look like a better version of myself. And that's what I've found, a better version of myself.
So you can obviously see here, like I said, there's been major improvements in lower third of her face, her neck, her forehead, the shininess. Under the eyes, we did some smooth eye. So there's different protocols that we do there. You know, and we do a lot of things now, like I said, as we've gotten more and more advanced. This is a case here, like I said, scars. This person had cancer on her nose from living in Florida and being out in the sun. And unfortunately for her, they couldn't just do a normal procedure and remove it. They had to actually remove a big chunk. She had to do 2 surgeries. The first time they didn't remove all the cancer, so they were a lot more aggressive the second time and had to make a rotating flap. And of course, then her skin was, you know, one over top of the other, didn't look smooth. And she actually came in and consulted, you know, like this, with her face covering her nose and, you know, very apprehensive, and asked me if there was anything I could do. And of course we said, yeah, there's lots we can do actually with lasers and with PRF and other things. And, you know, we did 2 treatments on her only, and we were able to heal this up completely. You can't even tell she's really had scars on her nose. You know, of course, she's very happy. You know, we've changed this woman's life. And I can tell you, doing these procedures in facial aesthetics, you can make your patients a lot happier than you ever could in dentistry. So it's really a nice field to work in. It's a lot of fun. This is just another testimonial of her, and just explaining what happened afterwards when we tightened her jowls and did other things. I'm going to skip over that. So, you know, we've gotten so busy at the office that in our dental practice that I showed you, we've completely outgrown it. I mean, it's gotten so busy that we've decided to create just a clinic where we're only going to be doing aesthetic procedures, and we'll call that Care Aesthetics. And this is, you know, got more of the med spa look, and it's being built right now. So it's going to be a lot of fun to migrate to this new facility. And we'll have a teaching center inside there as well, where we'll host courses and teach people how to do these procedures. So like I said, if anybody ever wants to take a vacation out in Florida, we're more than happy to accommodate you guys, and looking forward to seeing everybody and work with some of our doctors that work out of that facility as well. So I always tell people, never forget how big this facial aesthetic field is. It's really a booming market, and a good one for dentists to get a hold of. As I mentioned earlier, out of all the books that we had written, the biomaterial book, which I thought was going to be, you know, my bread and butter book, has actually not been my most sold textbook. It's been this PRF and facial aesthetic book. And it was so popular, and it was starting to be bought by not just medical providers like dentists and medical people, because it is a $150 book. It is bought half the time by patients. So what we found is that, and what Quintessence told me, was that a lot of people buying this book are actually just patients. They're so excited to learn about, you know, facial aesthetics that they buy medical books and they read the entire medical books. That's how excited they are about this field, which would never happen in dentistry, right? No patient would ever buy my biomaterials book or Dr. Picos's bone augmentation book and read the whole thing before they did a GBR procedure. But they'll definitely read the facial stuff, and they want to learn all about it. And so we've rewritten the book for patients. It's a much simpler version of the book. It's cheaper. It's just a nice short little paperback book that's $39 instead of $150. And it's called Care Aesthetics, a healthy way to natural facial rejuvenation. And it's for patients that want to enter into these more natural forms. And we're going to give copies to our patients to read and take home from all of our clinics across the country. And I think it's going to do quite well because of the growing demand for these procedures all around the world. And you'll note that in the book, one of the chapters is dedicated to the dentist, you know, and there's a chapter 4 here. Why should you go to the dentist to do these procedures? There's a whole chapter dedicated to that. And it talks about aesthetics. Like if you look at this person here, right, missing a tooth, the perfect example to show why the teeth are so central to physical attractiveness. Did you even notice the eyebrow? In a case like this, you know, he's missing an eyebrow. And when you first look at that photo, you don't even notice. Okay, that's how central the smile is. And when you actually look at the studies, they show that the 5 most important features to somebody's physical attractiveness is number 1, their smile, number 2, their teeth, number 3, their lips, number 4, their eyes, and number 5, their skin. And as dentists, we work with these three things every single day. And as dentists as well, like I said, we work in this area of working in millimeters. You know, if you make a crown, a central crown of an incisor 1 or 2 millimeters too long, it looks awful. I mean, it really looks awful. And their physical attractiveness is awful. And that's 1 millimeter. You know, we learn all these things. And so everybody in dentistry is trained to be cosmetic. You know, sometimes we have patients that come in and they'll say to us, is there a cosmetic dentist that works at Lakewood Ranch Dental? And my boss will say, there's no such thing as a non-cosmetic dentist, because if the dentist is not cosmetic, they're going to be out of business so fast. I mean, we're used to working in aesthetic zones. We're used to developing contours. Even if you do dentures, the importance of having the lip support and everything else related to that is just so important. So that's one of the points that's made in the book. Another point that's made in the book is, hey, take a look at the complexity of dental injections, right? Think of doing an inferior alveolar nerve block. That's your bullseye. And the book makes a point. Is there any injection in anywhere in medicine that is that complicated, where you have to twist over, look in that area, find your bullseye, assume where it is, have the needle go in an inch or, you know, a couple centimeters, on and on and on. These injections are so much harder to do than facial aesthetic injections that dentists are by far the best injectors of any profession we've ever trained. And to be able to do those injections and other things and then just go extra orally to the face, you know, there's a real big opportunity here for dentists to be involved in some of these procedures. So that's the reason why we're involved in a lot of those courses. So, you know, that's basically what I wanted to share today. If anybody has any questions, like I said, I'm more than happy to answer them right now. And I can be here for the next 10, 15 minutes or so answering some questions if there are some. Thank you.
So, Rick, thank you so much for the wonderful presentation. Let me say again that should they ask the questions in the Q&A box, or should they ask them verbally? What do you think?
Either or is fine. You can do
Okay.
either or.
Because there is one question already in the Q&A box.
Yep.
So if you want to see it, it's from Dr. Kalani.
Okay, I see it here. Yeah. Okay, so the question is, could a biofiller clot a vessel? So that's a really, really good question. Okay, and there's been a lot of research put into that question as well. The answer is, you know, in theory, it could happen, right? So there are, just like if you injected hyaluronic acid or Juvederm, these types of products, you could occlude a vessel. And there are counteractive agents like hyaluronidase where you can dissolve HA, just like there are products like liquid fibrinogen, and we teach the concentrations, etc., where you can dissolve a clot if you needed to. One of the things that was interesting, because people assume this for many years, right? If we inject a heated albumin, you could clot a vessel. And it has actually never happened before. So in all these years and in all the injections that's been done, there has never been one reported case of an actual vessel being occluded. Okay, not to say that it couldn't happen, but it's never actually happened. One of the reasons why a lot of people think it can actually happen is there's two reasons. Number one, a lot of people that work in the blood field think that your normal body has plasminogen levels. And when you inject, like, let's say liquid PRF into a vessel, let's say you were ever to inject it right into a vessel, they think that your normal levels of plasminogen would always prevent the clotting from occurring. Okay, so that's number one. And so if you talk to anybody that only injects liquid PRF, for instance, it's never happened where they've had any kind of occluded vessel. So there's a little concern there. With the biofiller, we always tell people, and this is very different than HA. If you were to inject HA into a vessel, the problem is, for those that do Juvederm injections and use hyaluronic acid, these expand, right? If you inject HA into anywhere, HA attracts water, so it will slightly expand a little bit. So if I put that in a vessel, it expands, I really block and clot that vessel. It's very dangerous. If I inject it even into a tissue and it expands and it just compresses some of these vessels, it can also be dangerous. With the biofiller, it's very different because when we do it, and we teach this in the courses, obviously, you're mixing 2 parts the albumin gel with 1 part liquid PRF. When you mix that, the final product is 2 parts of the biofiller and 1 part the liquid PRF. So out of this 2-to-1 ratio, 33% of this, the liquid PRF, is gone in the matter of, minutes, hours. So it actually shrinks, and it shrinks quite a lot, 30% or so. And we teach in the courses, we always over inject actually biofillers. So with HA, you inject up to a point, it expands a little bit. With biofillers, you do the opposite. You tend to over inject and then it shrinks. And by shrinking, it actually makes it a lot safer, because if I was to ever inject that directly into a vessel, instead of expanding, it actually shrinks. If I accidentally compress some of these vessels by over injecting too much, in the matter of 15 minutes to an hour, it's actually shrinking because the liquid PRF is dispersing itself a little bit, and the vessel is no longer compressed. So it's quite a bit safer. Now, we do still teach people, if they really ever gotten to a place where, you start to see tissue blanching like you would a filler, etc., you could always inject liquid fibrinogen, and we teach people how to do that as well. Good question.
Wonderful. If there is any other question and you don't want to ask it in the Q&A box, you can raise your hand. There's a button called raise hand, so you can ask it verbally. And actually, I think Christina from our team has a question for you.
Yes, hello from me as well. There is some interest in the Osopia graft. You mentioned that in your first webinar, of course, but we would like to, if possible, have some update on the which stage of clearance it is, and availability in the market.
Yeah, actually, that was another thing that happened over 10 years ago with respect to that research. So it was funny, actually, because somebody made a post recently about, the work that we've done with Osopia. I wish I had developed that product, but I didn't. I wish I would have, because the guys that developed and did all that work, they're from Netherlands, and it was a group in Netherlands, orthopedic surgeons, not dentists. And they were the first group in the world to show that these grafting materials that were made from synthetic sources could be inductive, which was really a breakthrough, because of course every synthetic bone graft up to that point have not been inductive. And this was a real big breakthrough, actually. We were the first dental group to show that it is inductive. So we actually contacted the group in Netherlands that had developed it, a group of researchers in orthopedic surgery. They created a company, and we were the first to test it in the dental field. So we did the first basic research, showed that it made bone and muscle. Before we knew it, in 2018, a group in the United States, an orthopedic surgery group, actually bought the company for, I think it was 30 or 40 million in Netherlands. So all of these researchers in Netherlands and professors became very rich. That's why I say I wish it was me that developed it. And it's currently sold by Nuvasive, which is a group in San Diego in California. And they're the ones that have the rights to it, and they bought the whole company in Netherlands. So I don't know if it'll ever be available, quite honestly, in Europe for commercial use, or what their plans are. Like I said, you'd have to contact Nuvasive and figure that out.
Sure. Okay.
Great. Thank you. So good. Rick, I think we don't have another question for now. So we thank you so much for the 2 webinars, and
Yes.
we hope to see you in Greece soon, actually.
Yeah, it'd be great to head over there at some point.
We should start working on this and let people know when you will be coming here.
Sounds good. Sorry.
Enjoy the weather in Florida, and we hope to see you soon, really.
Absolutely. Okay. Have a good one, guys.
Thanks.
Bye-bye.
Bye-bye.